Hi, everyone. My name is Nina Resetkova. It's 12 o'clock here, so thank you for spending your lunchtime session with us at Boston IVF today to do some lunch and learn. Very nice to meet with you all and talk with you today, answer your questions. Again, my name is Nina Resetkova. I'm a fertility specialist at Boston IVF. I work specifically at the downtown Boston location. And I have a wide breadth of patients. Looking forward to answering your unique questions today. I'd also like to highlight that we are today or this week celebrating Transgender Awareness Week. So for those of you joining in today, we are your allies, and hopefully we can get to a couple of specific questions if anybody has any for today. Okay, it is 12 o'clock. We are going to give everybody about a minute or two to kind of roll in here. And then we're going to pretty much just dive right into questions, because I want to make sure that we're able to answer all the questions that you have today. Last time we had a session, I believe it was kind of late summer, late August. We weren't quite able to answer all the questions at that time. So hopefully we can get to all of them today, and then leave you with enough time to finish up with your lunch break and then head back to work if that's where you're headed today. Just a message here that popped up. Thank you for joining us today. Please feel free to submit your questions with the Q&A. And so I'll be kind of jumping back and forth between the Q&A and the chat function. If you're joining us by Facebook or Instagram, you can put your questions there, and we'll do our best to transfer the questions to me so I can see them all and then answer them one by one. All right. Okay, perfect. So now we've had about a minute or two, I think, for everybody to start joining in. I'll just reintroduce myself for those of you who are just joining in the last moment or two. My name is Nina Resetkova. I'm a fertility specialist at Boston IVF, working in the Boston location. And today we are going to be doing a live Q&A. So feel free to put your questions into the Q&A function. We have had some questions a little ahead of this session. So for my team at Boston IVF, if you can put those in the Q&A function, then I can go ahead and start by answering those, and we'll jump into the questions right away. Okay. Perfect. So here they come. The very first question was, is your late 30s and early 40s too old to get pregnant? So very simple answer to the correct question is no, it's not too late. It may be more difficult to become pregnant on your own. There may be some more steps that you have to take to optimize your health to become pregnant, but there are many successful treatment options that are available for you in your late 30s or early 40s. The difference between trying for pregnancy in your early 30s or maybe even late 20s compared to your late 30s and early 40s is that you do need to get a fertility evaluation sooner or after a shorter time frame of trying for pregnancy, because we don't have a lot of time to waste at that point, because time generally equals egg count and egg quality, or changes in both. So we want to make sure that we are optimizing your chances of success with treatment. So if you are trying on your pregnancy journey and you've spent maybe 3-4 months without success, it's a really good time to start thinking about scheduling an appointment with a fertility specialist to engage in fertility testing, and then jump into treatment if you haven't been successful after about 6 months of pregnancy attempts. If you're in your early 40s or approaching your mid 40s, the time to start thinking about this may actually be even earlier, maybe even after a couple of months of pregnancy attempts. Keep in mind, it does take a little bit of time to get in to see a fertility specialist, maybe about a month or two. Usually takes about a month to do testing. And then if you're going through fertility treatment, if you're using your insurance for that, that insurance timeline does take a little bit of time. You know, it takes about 2 to 4 weeks to get approved for treatment. So it was a good idea to start on the earlier side to preserve most options. So the next question is, my initial consultation with the fertility clinic is still 2 months away, and I have no idea what to expect. This particular patient is self-identifies as queer, has a sperm donor, and is hoping to do IUI or intrauterine insemination. So can I speak to what happens from square one? So great question. We're happy to help. If you also, I would say, if you have a consultation that's a little ways away, do check in with your team about potential cancellation, getting on the cancellation list. If you feel like you already have a lot of the sort of pre-work completed, you've already identified a donor. Some of the things that you can consider, if there's any sort of donor quarantine process that needs to be initiated, perhaps you can start taking the steps to do so. We do have quarantine, we are able to quarantine sperm for known donors at our center, so that is something we can help you with. The other things you can do is really work on optimizing your general health, making sure that if you're a smoker, you're quitting smoking. If you are on any medications that would not be safe for pregnancy, you can talk with your primary care doctor and OBGYN and make a plan to transition off those medications. Working towards getting regular exercise, healthy lifestyle habits, and then starting a prenatal vitamin. If you're intending to carry the pregnancy, you generally want to be on a prenatal vitamin for about 2 to 3 months before pregnancy. So this would be a good time to kind of get started with all of those things to get you on the right track. But definitely, if your appointment's really far out, let us know if we can help. We may be able to get you in sooner. If your appointment is with us, then do call in and see if there can be any expedited timeline or cancellation you can get moved up. Perfect. The next question is, sorry, lots of questions here starting to come in. Can I discuss reciprocal IVF planning? Absolutely. Reciprocal IVF is a process where two partners who were assigned female at birth, meaning that they had or have ovaries in the uterus, are both interested in very intimately participating in the process of family building. Reciprocal IVF works by one partner undergoing stimulation of the ovaries to make many eggs. Those eggs are then extracted from that partner through an egg retrieval procedure, inseminated with donor sperm. It can be an anonymous donor, somebody who's not identified to the couple, or somebody who they know and the sperm's been quarantined. And then embryos are created, and then an embryo is transferred to the carrying partner in the setting of an embryo transfer cycle. So obviously very intense connection and very intense involvement in the whole process by both partners, one from a genetic perspective, one from a perspective of carrying the pregnancy. Really amazing way to build a family. There are basically two ways to do this. You can kind of coordinate the cycle all in one. So the partner who's going to be receiving the embryo and carrying the pregnancy can actually have the sort of uterine lining getting ready to receive the embryo along the same timeline as the embryos are being created from the other partner's eggs. Or most patients prefer to kind of separate into two parts because there's some stress in coordinating the process. It can be a little cumbersome, it can be a little tricky, and sometimes the cycle just doesn't work out. We can't always ensure that the timing works for both cycles, in which case you can then discuss the embryo outcome, the embryo, how many embryos there are, the quality of the embryos with your treating physician, and then make a plan for embryo transfer to the carrying partner. Chances of success are really, really high with this type of treatment, really based on the partner who is having the egg retrieval, their egg count, which is measured by some tests that we do to evaluate your candidacy, and then also their age. Okay, so if you're interested in learning a little bit more about this as part of your family building plan, definitely schedule an appointment. We can give you some additional overview as well as timeline and financials, which will be important. Now, the next question is, what should I expect during the initial consult appointment? Okay, so the initial consult, as I mentioned for an earlier question, is usually scheduled about a month or two out, so you have a little bit of time to prepare for it. It does involve filling out some paperwork, and that paperwork allows us to understand a lot more about you. If you're presenting with a partner, learn a little bit more about your partner as well, and have some necessary information ahead of your consult. So please, do your best to fill out those forms so we have as much information about you and your family history as much as possible. There's some additional steps in terms of getting some consents on file, getting a referral from from your primary care doctor if that's necessary with your insurance. And then at the initial consult, you'll meet with either a advanced practice provider, which is a nurse practitioner, or a physician's assistant, or you'll meet directly with your physician. You'll discuss and review your history, potentially your partner history as well if you have one. Talk a little bit more about any testing that would be required, or review any testing that you've had previously. If you've already had some testing done with some sort of online fertility testing company or with a prior clinic, we're going to want to have all that information ahead of your consult so we can give you as much tailored information as possible and potentially even guide you to a treatment plan if you've already had testing completed previously. For my patients who are coming in for egg freezing, for example, if they've had testing done within the last year, oftentimes we're able to review the history and actually make a treatment plan right at the consult so that they can move right into treatment within the next month or two, sometimes even with the next menses. If you're going through a more conventional timeline, you still need testing at your initial consult. We'll make a plan for testing. Usually that'll happen with the next menstrual cycle. Or if you don't get regular menstrual cycles, then we can make a plan for testing at random to figure out kind of where things stand and complete the fertility evaluation, and usually schedule a follow-up about a month or two down the line. And at that point, we can make plans for treatment. Okay. The initial consultation in most cases doesn't involve a physical examination. So most of the time it can be done kind of virtually or using telemedicine, kind of like we're talking today. We can convey a lot of the information that way. And then if a procedure or an examination is required, we'll schedule that for you in the coming weeks. After the initial consult, you'll also have an opportunity to talk with your physician's nursing team. They'll go through the details of testing, timelines, and we also get a chance to talk with a financial coordinator. And that's really important. If you have any questions about your insurance or any self-pay questions, they can fill you in on what the anticipated cost of testing or treatment would look like. For many of our patients, testing is covered through insurance, which is wonderful. Treatment may or may not be, depending on what your treatment goals are. Okay. All right, the next question, we're making waves here. What are the next steps usually for someone who hasn't gone through IUI, intrauterine insemination, or IVF, in vitro fertilization? So if you're brand new to treatment and you're meeting with your doctor and they're making a plan for treatment, if you are working through insurance, the very first step would be to get that approved, to get a pre-approval from your insurance. So we would submit that. And then most often you would be calling us with your next menstrual cycle. In some cases, we'll use some pre-medications to get you ready for treatment. Sometimes that includes a birth control pill or some pre-medications prior to your cycle. Let's first talk about insemination. It's usually a little bit more straightforward, and then IVF involves a little bit more technology, so we'll save that for a second. For insemination, you can proceed with the treatment cycle in two different approaches. Number one, it can be a medicated cycle, meaning that you're taking some form of oral or injectable medications to maximize the number of eggs that are being produced. Or you can do a nice natural cycle, which doesn't involve any medications and usually involves some form of tracking of your cycles, whether that is tracking with an ovulation kit or tracking with blood work and ultrasound monitoring that we can do for you at Boston IVF. As far as the timing of the insemination, it's usually performed within 1 or 2 days of either an indication that you're about to ovulate or have a mature egg that's developing, either from monitoring that you do at our center, which is a little bit more precise, or you have the option to do home tracking with ovulation kits. If that's a dependable, reliable method for you, it's something that you could do to reduce the cost of treatment, particularly if you don't have insurance coverage for that part of the process. The insemination, really very, very simple process for most people with normal anatomy. What we're talking about is a provider would place a speculum inside the vagina, visualize the cervix, and then put a very slender catheter through the cervix and instill the sperm into the lower portion of the uterus. For most people, this takes about a minute or two to perform, has minimal to no associated pain. For some people where their anatomy is a little bit more complicated, it can take a little longer. But in most cases, if you had multiple procedures like this, it's fairly straightforward. And then you can go back to your regular activities with the exception of, drinking alcohol or any sort of toxic habits thereafter, but there doesn't require any downtime. IVF treatment's a little bit different, okay? IVF does involve additional medications and technology. It also typically starts with your menstrual cycle, kind of like the insemination. But with IVF, you're typically taking injectable hormones for a length of about 8 to 14 days. It's very individualized, okay? So your doctor will prescribe a monitoring plan for you, and that's with blood work and ultrasound. Most of my patients have about 5 or so monitoring sessions throughout their treatment cycle. And that's really to track the progress and development of your follicles and have an idea of how many eggs may be developing and along what timeline. The goal is really to get a large cohort of eggs to develop together along the same timeline without any early ovulation into your body. We're trying to keep all those eggs growing, and then you finally take at the end of the stimulation a trigger shot to induce maturity of the eggs, and then we schedule an egg retrieval. And the egg retrieval is a surgery that's done in one of our surgical centers. If you're in the New England region, particularly in Massachusetts, you're typically going to be going to the Waltham Center. If you're, for example, from New Hampshire or Rhode Island, we do have separate OR centers there. So you'd be having your surgery in one of our other centers. If you're joining in from the larger network, then of course your surgery would be performed locally to you. Okay. The procedure can stop there for you if you are freezing eggs, for example, or if you're making embryos with IVF treatment, the eggs would be combined with sperm in the laboratory through a couple of different techniques, and then embryos would be cultured in the lab. And we do embryo transfers at day 3 of development in some cases, at day 5 of development in most cases, or patients may elect to do genetic testing on their embryos, which requires the embryos to be frozen while we're waiting for the genetic testing report to become available. And then you would meet with your medical team once the results are available and then make a plan for embryo transfer of any normal embryos. Okay. So that's a general timeline. Both treatments, IUI, intrauterine insemination, and IVF, they typically happen over the course of a menstrual cycle. So the timeline is similar, but the process of getting ready for them maybe different. And there's obviously a lot more medications required in IVF treatment and a surgery to extract the eggs. So it's much more involved, using a lot more technology. And ultimately, the embryos are cultivated in the laboratory in IVF. Great question. The next question is, can we talk about freezing eggs versus freezing embryos? So freezing eggs versus freezing embryos is a tough question, actually, and it's a very highly specific question, and it's highly individualized. So when I meet with my patients, I always talk with you about the pros and cons of both, which we can talk about today. The pros of freezing your eggs are really that you are preserving your own individual fertility. And depending on where you are in the setting of your relationship or potentially working with donor sperm, depending on what is the situation, you may be more looking to preserve your individual fertility, or you may be intending to preserve your fertility as a couple or create embryos. So that's sort of the initial difference. The second difference is that there's a lot more laboratory work involved in creating embryos and potentially genetically testing embryos. So the costs for embryo creation and embryo freezing are typically much higher than they are with egg freezing. And then folks have different perspectives on creating embryos with the intent of, using or delaying the use of them. Some people don't feel comfortable creating embryos if they're not sure if they're going to use them. So that would obviously be something that's really important to understand about yourself and explore. And then in terms of the sort of chances of success, embryos give you more information for certain, because if the eggs have ultimately fertilized with a sperm, you know about the embryo's development, you know about the quality of the embryos, and you also, in some cases, know about the genetic makeup of the embryos, if they're chromosomally viable. So they give you, more information, more insight about the potential for future success. But as I shared with you, it does come at a cost of, not being able to preserve your individual fertility. It's really preserving that of the fertility of the couple. So highly individualized, definitely something to talk with your provider about if you're exploring these two options. And then also explore with the financial coordinator what coverage you have, if any, for these types of treatments. Those would be important. And then, lastly, once you do have a fertility evaluation, and we know a little bit more about your unique case, your egg quality, your egg quantity, your age, things like that, that would give more perspective into which of these pathways would be advisable. And then the other question is a little bit more complicated. How many eggs would you need to freeze for the best chances of a live birth? It's very highly dependent on your age. So if you're in your early 30s, which, we're definitely advising for more people to consider egg freezing at younger ages to maximize your best chances of success, versus your late 30s, the number of eggs that you need vary broadly. So in your early 30s, you might have a very, very good chance of successful outcome with 10 to 15 mature eggs, whereas in your late 30s, you typically need an excess of 20 eggs, in some cases even more, to have an excellent chance of future successful outcome. For embryos, if they're genetically tested, the chance of success is quite high, greater than 50% per embryo. So in that case, we would generally recommend that you have multiple embryos available to give you your best chance of having one live birth. If you're interested in having a larger family, you may desire to have more embryos. Okay, that is such a nuanced question. I would definitely say talk with your provider about that, because if you have these interests in fertility preservation, your goals, your timeline for starting your family, your partner status, they all really inform how we would advise you to proceed with this. Okay, perfect. So going into some additional questions about the Q&A. So I think we had a chance to explain the IVF procedure that was asked, and I think we had some pretty good overview of that. So hopefully that's answered your question. The next person asks, any tips for picking the right doctor? How do I pick the right person after multiple consultations? There's a lot of things to consider here. Your feeling, your emotional connection, I think, with the provider is important. I would say clinic reputation, strong history of success and family building, also really important. Making sure you're working with a clinic that's providing you the breadth of options that you're looking for, particularly if you have a unique or challenging case. Proximity, having sort of easy testing locations that you can get to, where you're not having to come to a really inconvenient location for testing or for surgery. And then I would say talk with your friends or colleagues too, where people have had good experiences. That would be a good approach. We all we practice similarly, but we all have a slightly different approach to working with patients. So I'd say if you had a friend or colleague who had a really good experience and you want to, evaluate that if that person's a good fit, that would be a great place too. And then lastly, I would very strongly encourage you to work with a clinic that has a very well established and reputable laboratory. That's really, really important, especially if you are freezing your eggs, if you're doing IVF treatment, if you're working with egg donation or third-party reproduction. Boston IVF, we have a very strong laboratory. We've been operational for over 30 years, and I think had over 70 or 80,000 births in that time frame. So we have a pretty strong history there of good outcomes. So I would encourage you to definitely think about that when you're doing your decision making, and hopefully we can help. Okay, Charlie asks, if you have an extremely light monthly period, could that be impacting implantation or fertility? So it depends. Probably not if it's just your regular period that you've always had, and that's always been what your period's been, and there hasn't been any interval changes. However, an extremely light period that represents a change from your typical cycles, if something has happened and then your period has changed in character, that probably deserves some exploration. In some cases, people have had multiple surgeries inside the uterus. It may have lighter bleeding because of some issues that are going on inside the uterine lining. So I would really think about talking about this with your OBGYN or your fertility specialist if this is a change for you from prior pattern. If it's kind of always been your flow, it probably doesn't suggest any abnormalities. But if you're concerned, you should definitely flag it for your women's health provider so they can do any further exploration or testing, especially if you're thinking about getting pregnant or you're having difficulty conceiving. Okay, great question, Charlie. Next question from Karina. My partner and I are interested in doing 2 inseminations back to back. I have polycystic ovarian syndrome, PCOS, and will be using fertility medication to help grow follicles, and also will be using donor sperm. By doing this, would this increase our chances of becoming pregnant? And what are my thoughts about this? So I think the question pertains to doing 2 inseminations in one treatment cycle and one IUI cycle, which is reasonable. Kind of tell you the pros and the cons. The pros are that you will get more cumulative sperm exposure. And if your partner is not a sperm producing partner, then that would give you more opportunities to have sperm exposure. The sperm lasts for a while in the reproductive tract, so you probably don't need to do 2 IUIs. But if this is something that you want to do as sort of a last attempt before moving forward to IVF treatment, it's reasonable. I would definitely encourage you to consider the cost of sperm when you're making this decision. Most studies suggest that if you do 2 inseminations in one cycle, you may be increasing the success rate of the cycle by about 1 to 2%, which is a pretty small marginal increase in success rates when you think about the cost of donor sperm. In some cases, donor sperm is now $1,800 per vial. You know, the costs have really gone up after COVID. And so to increase your chances by such a small amount that may not be clinically significant, but increase your costs in a way that may be very significant for you, may not be worthwhile. So I would say talk to your provider about it. If it's something that you really want to try to augment the chances of success, it may be worth considering, but it is probably going to come at a higher cost. Now, if you're working with a known donor, somebody has donated sperm to you and you have many vials and the cost of one vial isn't so significant to you, then that may be and that may very well be an interesting idea for your treatment. So I would say this is a highly individual question again for you, but keep in mind that the cost is going to be a significant factor probably in the decision making, and then that additional procedure coming in for the additional insemination. So you'll be coming in to see us typically for monitoring, then again for insemination the next day, and then for an additional insemination the following day. So a little bit more cumbersome. Next question is, can I please share a little bit more detail on the timeline and the process of egg freezing? Absolutely. Egg freezing represents a significant portion of my practice here in downtown Boston. So I'm working with a lot of people to freeze their eggs and really working on streamlining the process and the timeline for that. We all have busy working lives. You know, we want to make sure this is not too arduous for you. So some of the things that we're doing are piloting some programs that can help you to actually do testing ahead of your appointment. So talk with our scheduling team if you're interested in exploring those options. If you're a good candidate, you may be able to do some pre-testing with an outside company to actually have ready in time for your appointment. If, however, you've done some testing with your OBGYN, as I shared earlier, please have those records sent over so we have that full information available in time for your consult. Typically, it takes about a month or 2 to schedule the consult. So if you're booking something now in mid-November, you might get a consult time maybe in December, and you should be able to do your testing with your subsequent menstrual cycle. The testing is most often quite simple. It's a blood work appointment and an ultrasound done in one visit, most typically done on the second, third, or fourth day of your menstrual cycle. And your results may be back as quickly as 1 or 2 weeks. In some cases, if you're doing some additional testing or genetic testing, the testing may take about 3 or 4 weeks to come back. So we can plan for follow-up to discuss your results and make a plan for treatment. In some cases, you may be able to move forward with treatment as early as the following menstrual cycle. So there are ways to sort of speed things up, and if you want to get your treatment done in a time-sensitive way, we have options available for that as well. Okay, the timeline for treatment, the active part of the treatment is taking injections and then doing monitoring of blood work and ultrasound to monitor the progress and development of the follicles on your ovary. Usually you're taking those injections very much like the timeline we just discussed, about 8 to 14 days. You take one final injection to mature the eggs, and then we schedule an egg retrieval for you. At the time of the egg retrieval, it's very important to know you're going to be under a light form of general anesthesia. So because we're using this type of anesthetic, you'll be fully asleep and you'll still be a little groggy after the anesthesia wears off. So you will need a ride. Very, very important. And we recommend you have a support person available for you through the rest of that day, just to make sure that you're feeling well and somebody who can drive you home. Okay, then we would follow up to discuss the outcome of that cycle. And then if you're interested in doing another cycle of egg freezing, you can make a plan for that within a month or two. Okay, chances of success with egg freezing, best in your early to mid 30s. However, the most typical time for people to freeze their eggs is kind of around 35 to 38. Interestingly, there was a cost effectiveness study done. It was done a number of years ago, probably about 5 years ago now, looking at the cost effectiveness of freezing your eggs, thinking about sort of societal factors like partnering with somebody. And they thought that the success rate and the cost and all that made actually age 37 to 38 the most cost effective time. I would argue that that those parameters probably have changed as we have more data coming out. Probably the best time to freeze your eggs would be in your early to mid 30s, and then just increases the likelihood that you're going to have to do more treatment cycles as you get older. So if you're curious about it, if you want to check out your ovarian reserve, definitely schedule an appointment with us. At minimum, even if you decide not to freeze your eggs, you're going to get some really good information about your potential fertility, if there's any red flags that are identified through the testing. Many people ask, do I need to take out my IUD? I have an IUD in place, or I'm on birth control pills. Do I need to make modifications? IUD does not need to be removed. Okay, you can go through treatment with an IUD in place. As far as birth control pills do temporarily suppress your ovarian reserve parameters, so the tests that we're using to assess your ovarian function. So keep that in mind. It's probably best if you come off birth control pills for 1 to 2 months to do your testing and potentially treatment. But if you're really nervous about that, or if you have some medical reasons where you're taking birth control pill, it's also possible to do your testing while you're on birth control pill and kind of discuss the results with your provider and see what that means. We can still give you some guidance. Okay. Hope that answered your question. Moving on to the next one. I recently had a hysteroscopy and they found severe scar tissue. The scar tissue was removed, but I'm worried about my chances of a successful pregnancy are low, and I'm considering surrogacy. What would I recommend for next steps? If you've had multiple procedures inside your uterus, you are going to be at slightly higher risk for developing scar tissue in the uterus. That scarring condition is called Asherman syndrome, and depending on the extent of the scar tissue or adhesions, or your body's propensity to reform those adhesions and develop further scar, you may or may not be a suitable candidate for receiving an embryo into your uterus or proceeding with pregnancy. But in many cases, you have the opportunity to try. The important considerations are what would be the effect if you did get pregnant. could you be at risk for any placental complications given the extent of scar tissue? Sometimes the placenta will form incorrectly. So it is important for you to have some counseling either with your OBGYN or your high-risk pregnancy provider to really understand what those risks are. In some cases, if scar tissue is minor, there's probably not going to be any significant impact on placentation and pregnancy. But if the scar tissue is major, there may be. I would also consider other things like your age and the activity of your ovaries and how many embryos you're really able to make through IVF treatment. If you have just a small number of embryos and you want to conserve those embryos for surrogacy, that's reasonable if it's difficult for you to make high quality embryos. If, however, you have a lot of embryos that are created because your ovarian function is excellent, then it may be more reasonable for you to consider a transfer for yourself, as long as you're aware of the risks and it's been deemed reasonable. So very nuanced question here and sort of a difficult answer, but all of those are considerations that your provider will be talking with you about when you're making your plan. And in some cases, if you've had, difficult journey already, it may be strongly advised for you to consider third-party reproduction, working with a surrogate, because the chances of pregnancy success in many cases may be very, very high with very low risk of complications. Okay, so let us know if we can help with your case. It sounds, sounds like something that you would want to talk with the provider about in depth. Next question is, what happens on the day of embryo transfer? Thank you. You're very welcome. The day of an embryo transfer is a very special day. Obviously, it's a day that we have in many cases been working very hard towards. Fortunately for you, it is a much easier day than usually the lead up to that embryo transfer, which usually involves shots, egg retrieval, surgery, and in some cases, multiple IVF cycles. So the embryo transfer day is generally a much calmer day. You will come in about 30 minutes before your planned procedure. We do ask you to drink a certain amount of water, and that's not to torture you. It is actually to get your bladder filled up moderately full so that the orientation of your uterus is a little bit more straight as opposed to curved up or anteverted. When the uterus is more straight, it's much easier to pass the catheter that will ultimately introduce your embryo into the uterus. And it's much easier to visualize what we're doing because of the way that the ultrasound technology works. It's much easier to see the image if you're transducing through water, like urine in your bladder. Okay, so usually come in about a half an hour beforehand. The actual process of the embryo transfer for most people, it's a very general statement, about 5 minutes. Okay, it involves meeting with the surgeon who's going to be doing the procedure, reviewing the embryo or embryos that you are transferring, signing any pre-procedural consents, and then meeting with the embryologist to review the information. And then receiving the embryo is very similar to other procedures that involve passing a catheter through the cervix, like a saline sonogram, for example, except we are transferring only sort of negligible, very, very small amounts of fluid. So you won't feel any distension on your uterus. It's really just placing the catheter under ultrasound guidance and then inserting the embryo in the upper portion of the uterus. So for most people, virtually no pain involved. In some cases, if your anatomy is a little bit more complicated, you've had a lot of surgeries, particularly fibroid surgeries or endometriosis surgeries, it may take slightly longer. There may be some additional tools that would be needed. But for most folks, again, 5 to 10 minutes for the embryo transfer. And then because the chances of success are quite high after the embryo transfer, you will take all the precautions, assuming that you are pregnant, avoiding alcohol, avoiding, undercooked meats, avoiding, raw seafood, things like that, avoiding smoke exposure. And then you'll have a pregnancy test in most cases 10 days later. And then we will let you know if you're pregnant from that transfer. Okay, so very, very special day, and I hope you're getting close to yours. Karina asks, my first IUI cycle was medicated with letrozole and did see follicular growth, however, was not successful. I have PCOS with cycles where this person is not ovulating, so they're anovulatory, and wanted to know what treatment options would be available for second insemination. Well, there's a couple of options for ovulation induction. Letrozole is an oral medication that you can take to stimulate your ovaries to produce eggs. It is an aromatase inhibitor, so it works by suppressing your body's estrogen level, and then it kind of tricks the brain into producing the hormones required to develop follicles, like follicle stimulating hormone. There's an opportunity in some cases to step up the dose of letrozole. There's also alternative medications that can be used, like Clomid. That's a selective estrogen receptor modulator, works differently than letrozole does. Most cases for people who don't ovulate regularly, letrozole actually works better than Clomid. It's been very well studied head to head, and letrozole typically has better success rates. But the alternative options, if those kind of oral medications aren't working, is potentially to add some additional medications to sensitize your ovaries, or use injection hormones, which carry a great deal of risk. So there's definitely some caution there, or alternatively IVF, in vitro fertilization. When you take injection medications for IVF, those work directly on the ovary. They actually stimulate the ovary directly by producing multiple follicles. And so even if you're resistant to oral medications like letrozole, injectable medications will typically work to stimulate the ovary. Okay, so probably a couple of the options to explore with your provider. Let us know if we can help. Okay. Next question is, if you are thinking you want to conceive at age 37, approximately, and you're currently 34, is fertility preservation advisable? The answer is it depends. It depends on multiple factors, including obviously your age you've outlined, but your ovarian reserve. What are your goals for family size? How many children are you interested in having? What is your partner status at that time? Are you single? Are you partnered? Are you married? So all of those would be considerations. I will try to answer a portion of this, is that taking into account maybe some sort of hypotheses here. If you are, let's say you're thinking about delaying your family building, starting at age 37, let's say you want to have 2 kids. Most of my patients typically interested in having 2 children. So you may have your first child at age 37, for example, maybe your second one by 39 or 40. It may be a little bit more difficult to expand your family at that time. So if you are interested in optimizing your chances of ultimately having a genetically related child, a child with the use of your eggs, you may be a candidate for consideration of egg freezing to help you expand your family down the line. As far as egg versus embryo, we kind of touched on those important differences. So it really depends, again, on your partner status. But if you don't have a partner at this time, egg freezing is a great option. The survival rate of eggs when they're thawed out is excellent in our laboratory. And although it's not quite as good as embryos, it's getting comparable. And so egg freezing is a great option if that's something that you decide to do. And again, egg freezing may not be necessary for your first pregnancy, but if you're anticipating having a larger family, 2 kids or more, it certainly may be helpful in expanding your family. Okay. Next question, how do people decide whether to genetically test embryos or not? There are some very clear reasons to genetically test embryos. Some of those include familial cancer history, so where your family has a known gene that runs in the family that affects the risk of you or your children developing cancer, sometimes at a young age. Known genetic conditions that run in the family that would also affect the health of the children. Or if you and your partner both carry a gene that runs quite in your family, nobody even knows that it's there, but it happens to be the same gene that's affected, in which case you would have a 1 in 4 chance of having a child that's affected by that condition, potentially very severe, for example, cystic fibrosis. So that would be a clear reason to do genetic testing for a specific indication, for essentially diagnosing the embryo, whether the embryo is affected or unaffected by that condition. There's also genetic testing for aneuploidy, chromosomal abnormality, and the decision there is complex. Largely, it's driven by age. Once you are 38, and this is again for the female partner or the egg producing partner, once you are 38 the vast majority of the embryos that you create are going to be chromosomally abnormal. At age 37 to 38, it's about 50%, and beyond that, it really accelerates the rate of aneuploidy. So genetic testing may be helpful to you as a tool to sort out between the embryos, which embryos are chromosomally viable and non-viable, and use it as a selection tool. It may also decrease your age-related risk of miscarriage, and that's important, particularly if you had multiple pregnancy losses. There's some data that suggests that people who've had multiple pregnancy losses actually have a higher percentage of their embryos come back as chromosomally abnormal than we would expect for their age. So PGT testing, pre-implantation genetic testing for aneuploidy may be especially helpful to you with that. Okay. And then, other reasons that people consider doing the genetic testing is if they've transferred back multiple embryos and they're young, there's no clear explanation of why the embryos haven't worked. And we're really trying to figure out the correct transfer order, picking the embryos based on quality and chromosomal makeup. So that's another strong indication. And then some folks will consider using it for family balancing down the line. So knowing that you have identified what proportion of your embryos are male and your male and female, that's important to them. And then a lot of our patients who are doing third-party reproduction, working with a gestational carrier or surrogate, will also opt to use genetic testing just to have that heightened embryo selection to increase the chances of success with the first transfer. Okay, hope that was helpful to you. It's not a straightforward question. In some cases, genetic testing is actually not advised for all patients. So definitely something to talk about with your doctor because there's definitely strong use cases for and against PGT testing. Okay. Charlie asks, what are the chances of secondary infertility? It's again quite variable. I don't have a specific percentage for you because it depends on your age, and it depends on whether you had any struggles or length of difficulty in trying for your first baby, and what is the gap of time between the first baby and the second baby. Secondary infertility is relatively common from a fertility specialist point of view. We work with a lot of families who have had relative ease in conceiving their first and second baby, and then are having difficulty for their second or third, or in some cases even larger family size. So secondary infertility represents probably about 10% of the patients that we see, if not more, really, again, depending on age and what kind of gap there is. Oftentimes what I see in patients with secondary infertility is that there were sort of minor issues that may have affected their journey in family building initially for first and second pregnancy, but it took them a little bit longer to conceive for a first and second baby than average, but nothing really notable. And then when we do the testing to evaluate, we find some additional things that have actually influenced their chances of trying all along, but it's amplified because now they're 2, 3, 4 years older than when they were trying for, first or second pregnancy. So if you're experiencing secondary infertility, it's still important to get an evaluation done, a full fertility workup to understand what are the causes and how it can be treated. Because there may be things, even if you've conceived relatively quickly before, there may be things that were actually contributing, but you didn't know it. So don't go too long, don't go years and years of trying if you really want to have another child. Definitely come and see us. If you are 35, if you're under 35, if you've been trying for close to a year, that would be the right time to schedule a consult. If you're 35 or older, if you've been trying for pregnancy for about 6 months, maybe make a consult about 4 or 5 months of trying, 5 or 6 months, then come and see us at that point. If you're over 40 or over and you're considering expanding your family, I would definitely come early in your journey just to do some testing and make sure there's no barriers for you having a good chance of success. Okay. Karina asks, I was recently prescribed Provera for 7 days to trigger my period so I can return to get baseline testing with my provider. How long after I stop Provera should I expect my period? Provera is an oral progesterone medication that essentially helps people who don't get regular periods to induce a period. And the way that it works is by removing that progesterone effect from the progesterone receptors, it allows for shedding of the lining and resetting a cycle. Most people will bleed within 5 days of stopping the Provera. If you haven't had a bleed within 5 days of stopping, check in with your team. They may give a couple of extra days, and then may want to do some additional testing if no bleed has occurred by that time. Okay. We are coming close to the end of our time, so I'll try to make my answers a little bit more brief. And we have just a sort of few more questions, so we'll try to get through those quickly, okay? Anonymous asks, what are your top recommendations for improving egg quality? Egg quality is largely dictated by your age and genetics. However, there can be things that you can do to optimize your overall health, which may positively affect your egg health. So number one, if you're smoking, stop smoking. If you're overweight or have some metabolic disorders, blood pressure, diabetes, etc., really work towards normalizing those parameters, getting regular exercise, trying to do it daily, healthful habits, healthy, well-balanced diet. Make sure you're taking your medications if you are hypertensive or diabetic to optimize your general health, and ultimately that'll favorably affect your egg quality. And then prenatal vitamin may be helpful as well. For some folks, implementing coenzyme Q10 or CoQ10 may also be helpful in specific cases, particularly increasing patient age. But number one is starting, by looking at your general habits and really focusing on that. Some things can be improved, but typically egg quality is very much dictated by your age. So don't be frustrated if nothing is changing per se. Your body and your ability to carry a healthy pregnancy will still be very positively influenced by those changes that you're making. Would I recommend a second opinion after a failed transfer? In most cases, no. The chances of success for embryo transfer are optimized around 50%, maybe 60% in best case. So unfortunately, it's very much part of the process to not have a successful outcome with each transfer. So I would definitely recommend chatting with your provider if you have concerns about the cycle. But in most cases, even in best case scenario, patients will need multiple embryo transfers consecutively to have an excellent cumulative chance of success. For most people, that means 2. In some cases, 3. If you're a little bit older, your embryos haven't been chromosomally tested. In some cases, more embryos need to be transferred to achieve a high chance of success. So if you've experienced 1 or even 2 unsuccessful embryo transfer cycles, that is not a cause for alarm, but it is a cause for regrouping with your provider, talking a little bit more about options. Does it make sense to try the same protocol? Does it make sense to consider switching gears and looking at something different? Okay, good question. How long do I have to wait after a miscarriage to do another embryo transfer? We want to make sure that if you've had a miscarriage, that your uterine cavity is normalized before moving forward with another embryo transfer. So typically we'll recommend an evaluation like a saline ultrasound or maybe a hysteroscopy in some cases to look inside either directly in the uterus or using ultrasound and saline media to distend the uterus. So if you have a miscarriage, usually it takes about a month to resolve your hormone levels, your pregnancy hormone levels. Usually you'll have a bleed within 6 weeks of the pregnancy loss, but the time span is about 4 to 8 weeks, and then probably 1 cycle to do any additional diagnostic testing. So from the start of a miscarriage to doing another transfer, probably a few months is a reasonable time span. In some cases, it can happen faster, and in some cases, it takes longer to resolve a prior pregnancy, particularly if any pregnancy tissue has been retained. So I think a few months is kind of the average, but it can vary shorter or longer. All right, Anonymous is about to start my first frozen embryo transfer cycle. Good luck. How many days in general between egg retrieval and embryo transfer? I'd say most typically, if you're doing a fresh transfer, most of our fresh transfers are at day 5. However, there are very specific cases where an earlier embryo transfer may be advised, and that's usually because your physician is being very thoughtful about your case, and they're considering some factors that would potentially lead you to a better outcome if your embryos are transferred earlier. In most cases, embryos transfer happens at day 5, so probably 5 days, which does give you enough time to kind of recover from the egg retrieval, resolve any bloating or symptoms that you may have had, any pain. Certainly, if any of those symptoms are persisting and it's time for transfer day, please be in communication with your team because in some cases, it may make more sense to freeze all the embryos from that first cycle and then come back next month to transfer your embryo when you're feeling back to 100%. Okay, good luck. Katerina asks, can you get pregnant with low egg reserve? Thank you. What an important question to end on. Yes, you can still get pregnant with low egg reserve. There's been pretty good studies looking at people's ability to become pregnant if they have low egg reserve, which is usually measured by low AMH or low follicle count on ultrasound, versus people who have normal ovarian reserve. And in most cohorts, it appears that the low egg reserve doesn't necessarily affect your timeline to become pregnant adversely, though in some cases it may increase your risk of miscarriage. So it's still important to be aware of this. It's important to get assessed and maybe set up a plan for repeat testing with your provider if it's something you want to do. But it is not a barrier or contraindication to trying to become pregnant on your own. So yes, even patients with very low ovarian reserve can become pregnant. However, there may be some markers, if very abnormal, that can serve as red flags that would tell us the timeline for potential pregnancy may be reduced. In some cases, some proactive steps would be needed to preserve your best option of achieving pregnancy, particularly if you're thinking about expanding your family down the line. So yes, great question. And I think a very important one to be aware of. Testing doesn't tell us, if you haven't been trying for pregnancy, it doesn't always tell us if you can get pregnant or not. But it certainly does give us a good understanding of how you will likely respond to fertility treatment. So that's really the benefit of doing the testing if you are considering egg freezing or IVF treatment. Okay, we have time for just this last question. Can I explain ovarian reserve testing? Yes, that's testing that's typically done early in your menstrual cycle. You, in most cases, will call us with the first day of your cycle. We'll get you set up for testing on day 2, 3, or 4 of your cycle. And it involves blood work and ultrasound. The ultrasound, we're actually directly looking at the ovaries, counting the number of potential eggs available on the ovary at that cycle. And then we're also assessing some blood-based hormones, usually the follicle-stimulating hormone, the estrogen level, and the anti-Müllerian hormone level. In some cases, there's some other tests that are also ordered. And they give us, through the combination of those test results, give us a better understanding of what is the activity of your ovaries, and particularly how that compares to other people in your age group. And you'll be able to understand what would be your prognosis for fertility treatment accordingly to your results. Okay, and the very last question is, I'm 39 and single and want to become a mother. If I want to have a baby within the next year or 2, does egg freezing make sense financially? It depends if you are really just thinking to have one child or multiple children, and it depends on the activity of your ovaries at this time. I'd love to say it doesn't matter, but 1 or 2 years can make a difference in your egg reserve and your ability to have successful treatment, as we talked about some of the changes that occur in your late 30s. So the fertility testing now would really give you a better understanding of whether any proactive treatment would be necessary now, or whether you possibly have the ability to delay by a year or 2. Knowing that in the next year or 2, it's going to be more difficult than it would be for you right now, but understanding also that if you're not ready, you're not ready. And there's a lot of things that need to fall into place for you to be ready to start your journey. So obviously very detailed set of questions that you need to talk about with your provider to make a timeline that's right for you. Okay. So we've had some wonderful questions today, and I think really broad, really interesting. As most of you, I think, know we have we serve all patient populations at Boston IVF. So if you have questions or anything, kind of that's very unique about your family building journey, definitely let us know. We will do our best to help, and we've helped many before you. So it's been my pleasure to talk with you all today. Again, my name is Nina Resetkova, fertility specialist at the Boston Center of Boston IVF. And once more, for those of you who weren't with us at the beginning, happy Transgender Awareness Week. We do a lot of work with the trans population at our center. So if this applies to you, let us know. We're happy to help. Have a great day, everyone.